Hello everyone, and welcome to the Work of Workplace Mental Health webinar with Dr. Cindy Malachowski. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar has been made possible through the support of the community gaming grants through the BC government, as well as through donations and memberships to our organization. As mentioned, my name is Tanya, and I'll be moderating the session and handling the Q&A. And our speaker today is Dr. Cindy Malachowski. Dr. Malachowski is a Social Science and Humanities Research Council of Canada, SSHRC, funded postdoctoral fellow at the University of Waterloo. She's an occupational therapist and a certified psychiatric rehabilitation practitioner with over 10 years of clinical experience in a variety of clinical mental health settings. Her current research investigates the implementation and use of employee and family assistance programs within a variety of organizational settings. Cindy, we're very glad to have you here with us today. I will hand it over to you.
Great, thank you so much, Tanya, and hello everybody out there, and thank you so much for joining us, I guess this morning and this afternoon, depending on where you're located. Just to give you a little bit of background, a little more background about who I am. I have an undergraduate degree in kinesiology from McMaster University in Ontario. And then I went back to school and became an occupational therapist, and I fell in love with all things mental health. So I did practice clinically, as Tanya had mentioned, for 10 years in mental health in inpatient settings, outpatients, forensic settings, all across the board, and became a CPRP during that time, which is the Certified Psychiatric Rehab Practitioner. And then I decided I wanted to try to make a little bit more of a change at a different level as opposed to frontline clinician. So I went back for my PhD, and supervised by Dr. Bonnie Kirsch, my work turned more towards workplace mental health. Now, the interesting thing is, through my PhD, I was immersed in the world of sociology, which was new to me at the time. And not only that, my research approach took up a very strong critical feminist perspective. So I felt like a little bit of a fish out of water, but it did open my eyes to looking at the world through a new lens. And I'm really excited to share some of the findings with you today. So just a brief overview. I'll do a little bit of introduction to my research, talk a little bit about the approach I used called Institutional Ethnography, let you know how I collected my data and how I did my analysis, give a more detailed overview of the findings and implications and future directions of my work. So I think we're all well aware that workplace mental health is a pretty predominant theme nowadays. In Canada alone, it's over $51 billion a year to our Canadian economy, and the costs are increasing. They're double the cost of the average of other claims. They account for 47% of approved disability claims in the federal civil service, and that's almost double the percentage of 20 years ago. And of course, aside from the economic costs, it's a significant social burden for individuals. It affects every aspect of their life, their families, and the people who love them. And there's a lot of intervention programs that have come up to start, to address workplace mental health. And I think the problem is so systemic that it's going to take a lot of approaches from a lot of different perspectives to make a change. And my supervisor, Bonnie Kirsch, has a long-standing career in workplace mental health, and she really saw the need to look at the problem through a new lens. And that is how we stumbled on institutional ethnography. It's packaged as an alternative sociology because it really has an ontological shift. And what that means is it makes us question how we come to know what we know and how we view the world. It's grounded in an activist approach, so a lot of activists have taken up this perspective to look at how the world is structured to shape and produce individual experiences. So the epistemology is quite evident in the data collection in that we look at data slightly different. And it takes up the standpoint of individuals being ruled. So those are typically marginalized populations. So individuals living with mental health problems tend to fall on that spectrum. So for example, here's a series of dots. So traditional research would say, okay, we can count the number of dots and we can measure the distance between them. We can measure the size of the dots, and we could actually ask the dots how they feel or how they feel about being close or far away from other dots. We can really investigate a phenomenon through, those traditional approaches. But when we look to institutional ethnography, instead of looking at the dots per se, we look at the invisible relations that connect or join the dots. So these are all of the practices, documents, policies, social relations, and institutional relations that are happening that we're not always cognizant of, but they're there and they're actually shaping our experience without us really even knowing it. So in institutional ethnography, we look at the problematic or the puzzlement. So that's going to orient us to the direction of the research. So for workplace mental health, it was kind of this whole disjuncture between different versions of reality. We have these wonderful policies in place and legislation that protect workers experiencing mental health, but the worker experience is very, very different. Although we have these good things in place and these measures in place that are supposed to help us and facilitate support, the worker has a very, very different experience in the workplace. So it's really trying to understand how these two things are coordinated or not coordinated. So it's also important to just give a high-level overview of the dominant discourses that are circulating around workplace mental health. So traditionally, mental health has fallen in more of a medical discourse. So anything that falls outside of the spectrum of normal is considered bad and it should be cured or remedied because the ultimate objective is to become normal. But lately, there's been a paradigm shift, and that maybe it's not such a medical issue, that maybe it's more a psychosocial issue where, we're looking at things like socioeconomic status, increased in acceptance of diversity and presentation of behavioral issues, just really, a more accepting approach. So this causes a little bit of a tension in that, are we looking to treat or cure a mental health problem, or do we look at more of an acceptance and an integration and participation in diversity? So there have been a launch of anti-stigma campaigns, especially in Canada, leading nations such as Australia and the United States. So here at home we have Bell Let's Talk, Mental Health Works, and then a lot of these anti-stigma campaigns kicked off in the 90s, and it was kind of positioned as mental illness as an illness as any other. So they would say it's a brain disease, similar to diabetes and heart conditions, you have to take your medication. So that kind of underlying foundational anti-stigma approach is still resonating in some of the campaigns, and it has implications that we'll talk about in a little while. So for my data collection, I was fortunate enough to have access to an industrial manufacturing plant in Ontario. I spent over 140 hours at the plant, and most of that was engaged in ethnographic observation. So I got to hang out with the workers, I would attend team meetings, shift changes, I was there days and nights, and really immersed myself in the workplace. I took copious amounts of field notes, and I had 17 interviews with informants. And here's where the research is a little bit different perspective from typical traditional research, where I wanted to learn from these informants. I didn't necessarily want to learn about them. So although they were sharing their stories and telling me about them, I didn't want to mean that I disregarded that, but I was trying to learn from them what forms they filled out, what documents they completed, how their care, treatment, and performance was coordinated in the workplace. So that led to the collection of a lot of texts, be it collective agreements. There were 2 different labor unions present in the plant. Anything from vacation slips to sickness absence forms, policies and procedures from the corporate level, really collecting all of these texts and figuring out how they were activated by the workers and people who helped facilitate their process. So starting from the standpoint of the worker with mental health problems, that's the location where all this research came up from. So we really wanted to find out how their experience was shaped. So through these interviews and field notes and documents, we got really concrete descriptions of what the workers were doing. So we made visible the how, not necessarily the why. And we did this through mapping. So we would look at the worker's action, looked at the texts that kind of informed that action, and go back to the subsequent action that followed through. So basically it was tracking the overarching policies, paperwork, and text that were coordinating these actions. So I'm going to discuss 5 major themes that came from this work. The first is the employee's work of managing and negotiating episodes of mental illness. The second is the manager's administrative work of maintaining privacy and confidentiality. The third is the processes of authorizing episodes of mental ill health. And that basically references how do you know for sure if somebody's ill, and how do you start that documentation. The fourth is we're going to talk about formal respite from work. And the fifth is informal respite, so the work of hiding when unwell. Okay, so first, the employee's work of managing and negotiating episodes of mental ill health. So this particular organization had a very extensive, detailed attendance management process, and they were quite proud of the fact that it was so comprehensive that they felt they could catch somebody who was becoming unwell very early on in the process, so that they could offer supports and they could do intervention early on before that employee became so unwell they required extended sickness leave. It was challenging because it didn't necessarily take into account the episodic nature of mental illness. So what happened was, instead of triggering this detailed attendance management process, the employees started taking vacation time instead of sick time when they became unwell. So a quote from one informant said, "So I got hauled in because I had 2 absences within 3 months. And I was saying, that's 12 hours. And they said, that's right. And I said, at the time, I could take 4 12-hour shifts off and I wouldn't be in the office getting chastised, which is like 48 hours, right? Because that would have been one occurrence. And I tried to reason with them and that didn't work." So this extensive, program they had in place really didn't make sense to the workers. It was actually more of a disincentive. They didn't see it as helping them. They saw it as being punitive for them, because any time you got hauled in to an office, it was never a good thing. And the second finding, we looked at the manager's administrative work of maintaining privacy and confidentiality. Oops, sorry. So obviously there's a lot of privacy and confidentiality issues, especially when it comes around to mental health and disclosure and accommodations. The managers really, really struggled with this because they weren't privy to the actual diagnosis of the individual, and oftentimes they weren't even given any indication of what the symptoms might be for that person or how they could accommodate them. And this is really captured in one manager's quote. They said, you have to interview people for being sick, but not really know why they were sick, and you have to encourage them to be here, but you don't really know anything about their wellness or their sickness because it's all confidential. The company wants us to get people back in the workplace. On the other hand, you have no idea what's wrong with them. So this really showed a big disjuncture between the process of identifying somebody who's unwell and then all the filters in the organization that make the manager not be privy to the information they need in order to provide appropriate supports, or to talk to their worker in a way that demonstrates understanding and empathy. And of course, this all fell back on legal concerns between accommodation and harassment. So some of the managers I spoke to had no problem in picking up the phone every other day and contacting their worker to say, how are you feeling today? Any idea when you're going to be back? How are things going? Without actually talking about a diagnosis. And in speaking with some of the workers who had similar indications with similar interactions with their management, I had reports from workers who would say, it was a really welcomed conversation. because they felt that they were still being connected, somebody still cared about them at work. And I talked to other workers who said, you know what, when I'm on sick leave, leave me alone, I'm sick. There's a reason why I'm not at work, and it's because I don't want contact with work. So that was taken up by the workers in very different ways as well. And then I had other managers who really avoided these phone calls. They almost tried to call when they knew somebody was most likely to not answer the phone either early on in the morning, and would leave a really brief, curt message, just, okay, checking in from work, so they could kind of check off that tick box of, yes, I called in. And, in speaking with management about that, there was a definite expression of fear and concern over, being accused of harassment, harassing the employee, of asking questions that weren't appropriate, and basically breaching legislation or policy around protecting somebody's right to privacy. The third major finding was looking at the process of authorizing episodes of mental ill health. So authorizing a bona fide illness was a highly medicalized process. So in order to access any short-term or long-term disability, you had to establish first that your illness was legit. So in order to make a mental health issue formally recognized, it required a physician's signature on a medical absence form. So most often it was a GP or family physician who provided this sign-off. And unfortunately, we know from the literature that oftentimes GPs or family physicians are almost the, and I apologize if there's any GPs or family physicians listening, but are almost the least likely healthcare profession to properly diagnose, treat, and follow up with mental health problems. So that in and of itself is quite problematic, where we're relying on a healthcare profession who doesn't have the proper support in order to work with these clients and get them back to work for their, authorized signature to say, yes, this person's ill. So we sent out a recruitment for, I believe it was 6 to 60 physicians in the local area of this plant, and we had one physician respond. So I only had opportunity to speak to one physician, and they did say, in regards to authorizing a bona fide illness, a direct quote was, "I'm very lenient with the patient side. So for the most part, I'm kind of like, where are you at? What do you think you need? And if it's reasonable, then, I'll give it to them." So, it works, but it definitely opens me up to someone saying, yeah, I need to be off for the rest of my life. So obviously, I have to really work that out. So I felt this quote really kind of encapsulated the lack of support that physicians have. There's really no guidelines, no communication with the workplace, not really, demonstrating an understanding of the importance of connecting that person, with supports. So all of these factors came into play. And it was also very interesting when the family physician has to sign off on this form. The form is very medicalized in the phys med context. So you would have tick boxes and columns for, can't lift over a certain weight, can't bend, can't sit for too long, all these very, very phys med implications of being on leave. And the only, there was one tick box that had something to do with cognitive capacity. Whereas, the informants I spoke to really referenced times where they were exhausted or tired, times where, they were very thirsty and they couldn't have easy access to water frequently because of the nature of their work, or, needed increased washroom breaks. So kind of these physical and mental health issues, there really was nowhere on the form for the physician to identify any of those reasons for needing time away from work or needing accommodations at work. And that ties into the next finding on the, authorizing episodes of mental ill health. It also created a big disjuncture between the role of the manager, or rather the perception of the role of the manager through the manager's eyes. The manager, typically, I think, assumes they're going to be managing workplace behavior, And then because mental health has been positioned as such, a medical process, they don't feel that that's either in their scope or they have the proper skills to deal with that. So one manager said, mental health really is an area that should be left for people who have the necessary skills or capabilities to deal with that. Physicians, doctors, psychiatrists, and psychologists. So it really gave the managers, it positioned them so that they wanted to take a hands-off approach because they didn't feel prepared, or they didn't feel they had the expertise to do that. And it was almost set up that that was an acceptable practice because it is so highly medicalized that they didn't have to get involved. And so here we see that the actual worker, the individual that everybody's trying to support and everybody's trying to get back to work, actually disappears. And we're really focusing on these documents, these texts, these formal diagnoses, these written accommodations. The worker really gets lost in this process. One of the fourth major finding was looking at formal respite from work. So we have forms that are required, for a diagnosis and a physical limitation, any visible restrictions. So it really positions mental illness as an illness like any other. And it really shapes how workers come to know what their employer expects of them in regard to sick time utilization. And this really came to light when we had one informant who said, I took a vacation day because I couldn't justify it in my heart as a sick day, which was wrong because it was a sick day. I was not at work because I was sick, but I didn't sit at home and wallow. I went on a hike and I did all of the stuff to help me. So I thought to myself, how can you be on a sick day if you're out hiking in the woods? But really it was a sick day because I wasn't capable of working, but sitting at home would have been worse. And I heard a lot of stories through the informants, where they second-guessed themselves. They second-guessed the legitimacy of their illness. One informant said, when you call in sick, my manager doesn't believe you unless you're hacking, coughing, or puking, like you have to be throwing up. There's no other reason for you to not be at work. Positioning mental illness as an illness like any other, and there's no description of some of the symptoms that people are experiencing on these forms or in this process, the worker seemed to actually question, am I legitimately sick? Can I go into work? And it really positioned their illness in a way that they just didn't even know themselves anymore. And the fifth major finding that we had related to informal respite. So calling in sick or taking a vacation day is a formal process. There was also an informal process going on at work, and we found that that was the work of hiding when becoming unwell. So this is when workers who are living with a mental health problem are able to go into work, but something happens during the day, either like a trigger or all of a sudden they just start becoming unwell while at work and they need immediate respite from work. So we found that the frontline staff would typically engage in literally physically hiding. One worker would actually go find an area in the plant that he knew wouldn't be occupied, and he would have a nap. Another worker would go to the washroom and say they had an upset stomach and spend 20 minutes to half an hour in the washroom so that they could cry, or they could just have that break. So the frontline staff really recognized the fact that in the workplace they're either sick or they're well. So the lack of acknowledgement of mental health issues falling on a spectrum of wellness really came to light when we saw the workers were actually physically hiding. Now on the management side, that hiding looked a little bit different. Because managers have the ability to flex their work practices, they would restructure the time and location of their work. So when management who were living with mental health problems started to become unwell, they could take an extended lunch break, they could leave early, They could come in late. They could arrange to work from home. And oftentimes they said they would be home, they would work, flex their hours till later in the nighttime because they would be up anyway, and that's when they would get their work done. So it was much more easy for management to deal with the intermittent unwellness at work than it was the frontline workers. And so that really just speaks to the nature of strategic use of time and space in the workplace, and really how we need to think about that somewhat differently to accommodate these workers. So what's kind of the overarching, I've thrown a lot of findings at you, so what are the overarching implications of this research? Looking at sickness absence management programs in a different light. On the one side, this organization thought this was a lovely, supportive, comprehensive plan, and the workers perceived it as punitive and cumbersome, and they did anything to avoid triggering this plan. Also looking at how our workplace documents and policies align workers' consciousness and actions. So looking at the types of illnesses that typically constitute a legitimate or bona fide illness, like on those medical forms that go to the physician, the wording and the categories that are included in that form. And being cognizant that all of this kind of tends to taint what the workers think of their own mental health, and it makes them question the legitimacy of their own illness. It also speaks to the workplace in the workplace's lack of acknowledgement of variations and symptoms of mental health. It's not necessarily you're well, you're unwell. A lot of these workers did live with some mental health problems and could work, but they would have tough days or tough afternoons, or they might need a couple hours to work through something, whereas the workplace says, no, you're either sick or you're not sick. So how do we position that more as mental health as a continuous spectrum of states as opposed to an ill or not ill? I really learned through this research that managers distance themselves from the medical aspect of mental health problems. That probably has to do with mental health literacy, all kinds of different things, but I think it's really important that managers are the conduit in the workplace between the frontline staff and HR and all of those things, and managers are charged with ensuring the productivity and mental health of their workers. So when managers don't feel like they can engage, it's a pretty big disservice to the worker. So there's definitely a need for managers to better understand their legal liabilities and responsibilities in supporting workers with mental health issues. Nobody that I spoke to was really, none of the managers rather, were really comfortable with their knowledge. They would often default to a policy and follow it to a T, or legislation, or again just kind of take a hands-off approach and say, well, it doesn't, I'm a manager, I'm not a mental health expert. So we really, really, really need to look at better coordination between the corporate and the healthcare sectors. Oftentimes, a worker would be deemed, away from work, short-term sickness absence, or what have you. There was literally zero communication between the family physician and the workplace. Sometimes when the family physician and the workplace did connect, it was at a level that, none of the support trickled down to the management. And it was just, I'm not saying confidentiality and non-disclosure, those need to be in place, they need to be respected, but I think we need to work the system prioritizing confidentiality and non-disclosure in a way that is actually more supportive for the worker. So it has implications for policy as well. So again, we need to look at our definition of recovery in mental health and how that clashes with traditional medical discourses. And again, that ties back into either you're sick or you're not sick. And we need to look at these accommodation practices that are more flexible. So putting in accommodations that are going to account for the everyday experience of the worker. Again, the definite clear need for better coordination between corporate and healthcare, more support for issues of confidentiality and non-disclosure, and accommodation Oh, you know what? My apologies. Those bullets are quite repetitive. So I think I really wanted to hit home the fact that these are very key things that we need to work on. So the good news is, as far as future direction goes, again, looking at enhanced system coordination and communication. There's some new research that's come out by some top researchers, who happen to be some colleagues, looking at best practice guidelines. So there is a movement to try to provide supports for physicians and workplaces in helping workers get back and staying in work. So this best practice guideline research was a systematic review done, and it was internationally on best practice guidelines. So in summary, there were 3 agreed upon points, regardless of where this research was coming from, what country it came from. There were 3 strong points that were consistent across all of the papers that were reviewed. And that was the importance of well-described organizational policies and procedures for the roles and responsibilities of all stakeholders, the organization having a disability leave plan, and work accommodations that were clear and promoted in the workplace. And this included supervisor training and mental health literacy training for all staff. So that also really aligns with my findings from my research, again, just emphasizing the importance of all of this. And also taking up the standpoint of the manager. So my work looked at the standpoint of the worker and how their experience was shaped. But also I had a lot of empathy for the managers I spoke to, because they really had a vested interest in their workers, but really had no idea how to go about supporting them. There was a lot of fear. So I think, looking at this process not only from a corporate perspective or frontline perspective, but taking that manager perspective, because I really think they're key and critical in this process. There's also another scale that has come out through some research this past year. It's called the Return to Work Obstacles and Self-Efficacy Scale. So what this measure does is it looks at literally obstacles and barriers from the worker perspective as to how to facilitate that return to work. So, when provided with the opportunity to fill out this scale, it really identifies the things that are preventing that worker transition to the workplace. All right, so I talked really fast because I thought I was going to be long. So it looks like I'm done a little bit early, probably to much relief. So I just wanted to say thank you so much for joining in today. It was a pleasure to have the opportunity to share my research. I'd also like to thank the Canadian Institute for the Relief of Pain and Disability, and especially Tanya and Mark for all their help and support. This work was also done with my thesis committee members, Dr. Bonnie Kirsch, Dr. Catherine Boydell, and Dr. Peter Sawchuk. I'd like to thank the funding sources as well that supported this work. So I guess now we'll move on to a brief discussion, and if there's any questions, I'd love to hear.
Wonderful. Thank you very much, Cindy. That was a very good presentation. We don't at this moment have some questions, so I encourage everyone to go ahead and type in your questions into the question box so that we can have Cindy answer them, since we have her online. I was curious, Cindy, what are next steps for you in regards to this research? Like, are you pursuing a next topic related to this?
That's a great question. Thank you. And actually, that's my postdoc was funded through a spin-off from this work. So not only did this organization, they're really quite proud they had this comprehensive absence management program. They really did have a very strong employee and family assistance program. So in speaking, with the management side of things, they're like, we have this wicked program we offer to our employees. It's amazing. It covers everything. It's so comprehensive. And when I spoke with the workers, they would say, we hate our EAP program. We never access it. It's horrible. We have no choice. We have capped services. And I thought, how does this happen in the workplace where there's such a huge disjuncture between the intent of a program and how wonderful it seems and the actual uptake on the front line? So I did write a proposal for my SHRC postdoc. I did receive funding for that. It's been a struggle to do any further research on that topic, only because I didn't realize going in, in hindsight, it's crystal clear. It is quite a political topic. So from what I gather from some of the reviews, of proposals to delve more into that research, it's kind of like, well, why would public money be used to fund private industry? Because it was seen that integrating EAP services to enhance, worker mental health was seen as, well, we're actually helping private industry. Where I was coming at it as a coordination of service and how can we all work together, it could be viewed differently. So unfortunately, my work hasn't taken up that string of thought as much as I had hoped. But yeah, so
all right.
Continue on with the workplace mental health theme.
There was a question about what journals are the majority of this research published in?
I have one paper under review right now. The other paper has been published in Society and Mental Health.
Wonderful.
And I do have one other paper that's published in Forum Social Qualitative Research.
All right. Someone asking, how do you balance a medical note that states stress leave and start the conversation around limitations and restrictions to try and assist?
Yeah, you know what, that's a really good question. And as soon as I heard it, I remembered the physician saying sometimes he would just say, very vague comments on the sickness absence form. I have no direct answer, but I can give you an example of a program that worked really well, and it's through CIBC. Instead of dealing with limitations and workplace restrictions and accommodations in kind of that limited capacity, what they did was brought in a third-party mediator type position, and they would say to the worker with management, what can you do? What are the things you feel you can take on? So they really took this positive perspective and working with the worker, either they could do their work but from home, or they could do their work, a couple hours here, a couple hours there. So a diagnosis was never necessary. Work restrictions per se were never necessary. It was, really on this positive note of how can we help you do what you can do and be supportive in that light. And I think that program, I believe, I don't have the information with me, but I believe it has been published, and they've had some really great successes, and they do have, I think, psychometrics on how well that program is working.
Great.
I don't know if that answers the question, but
the person who asked that question, you can follow up with me in the questions if you need more information. Mm-hmm. Let's see. Someone asking, how did you find an organization that was willing to be part of this research?
Oh, another brilliant question, and thank you for that, because it took 8 or 9 tries. Organizations do not like people poking around their employees, especially when it comes to mental health, and that's not necessarily a negative thing, because the corporations that I did approach were very protective of their workers, and they just felt, you know what, if they are dealing with mental health issues, we don't want to stress them out further by having a researcher around. And, I really understood that, and it was, sheer persistence and I think a lot of good luck that I did find an organization that would provide me with access. And I think it was because they felt they had such a strong program. They were really proud, and they were really open to looking at, what could be improved or what could be changed. So I think most of it was luck.
All right. Someone asking, it seems to me a large number of currently incarcerated individuals are in prison due to mental health issues. Is there any way to integrate what you research and have identified into that specific setting?
Wow, that's another good question. So that's a whole field of research in and of itself. And yes, the majority of population in prisons do require mental health support. There is no doubt about that. Right now, they're trying to come up, the mental health system, at least in Ontario, is trying to come up with, diversion programs where police or individuals who are in trouble with the law, depending on their depending on what they've done and depending on their state, they do this court diversion program where they are, moved towards the mental health centers and tertiary care as opposed to putting them in prisons because they recognize that, they're not going to get the care they need, and that's just pretty much not a good path to be put on. So my work in workplace mental health doesn't necessarily intersect with that population, but it definitely doesn't mean that there's a high need for it. More attention there as well.
Another question, does the return to work obstacles and self-efficacy scale deal strictly with mental health, or is there a component for physical impairments?
Oh, my apologies. Yes, definitely. It's definitely both. It does address physical and mental health, and I believe it's the common physical disorders and common mental health disorders in the workplace.
Okay, great. And what is the best way to manage those who need immediate respite without having them disclose that they have a mental health issue?
That's $1 million question. I wish I had the answer. As I said, what we found was frontline workers, unfortunately, went to the washroom or hid, literally. Even one informant would just go to the parking lot in their car. I think that's something that our workplace policies, even workplace culture needs to start addressing. In the immediate future, I wish I had some really solid suggestions, and I wish I did have the answers, but I think that's something that has to be worked on, from all stakeholders as to how we change that and provide opportunities for those intermittent, breaks and things that the workers really need, because oftentimes they don't need an entire day off, or, and I really empathize that. I don't think there is a really easy answer for that just yet, but I'm hoping that it'll be on the horizon.
All right, and somewhat related, when someone is returning to work with a mental health issue, what strategies or trends do you find help with motivation in the individual who is returning to work?
This is when I wish webcasts were a little more interactive, because I would ask for a few more details. Oh, and I apologize. Sorry, the odds of my dog barking were 1 in a million, so I'm just gonna...
No problem. I actually have my dog at work, and he was barking while I was on mute during the presentation, so I was glad that I was muted at that point.
Thank you, and I do apologize for that. Anyway, my apologies. Okay, so I think what we found most successful within the organization and within the people that we did interview was a positive approach and an open approach. If workers are willing to communicate, they don't necessarily have to disclose specifics about their illness, but if they can disclose, what they can do, if they can engage in that communication, it was that communication breakdown that really impacted, the transitions. It's when nobody was talking to anybody else, no information was getting shared. It was kind of this awkward, I don't want to ask too many questions because I don't want to be accused of harassment, and the employee was so protective of, their personal right of non-disclosure. That's when things broke down. But if it can be positioned in a really open, honest, positive, communicative state, that's where most of the success came from. And the worker really needs to express their needs and work with the employer in order to get those supports in place.
All right, and someone's asking, or saying, I like the idea of discussing with the employee, but the practical aspects of if one employee gets a particular modified set of duties, the fear that other employees would ask for the same is of concern. And I guess my question is, as much as we might think we have an enhanced DM program, there doesn't seem to be a perfect system as much employers might believe it to be.
Yeah, no, there's definitely no perfect system, and every time you make one change, it will have a ripple effect in other areas. But, even as an occupational therapist, I can speak to the fact that, I think we always use the example of if a building isn't accessible and you put a ramp in for an individual with a wheelchair, like all those other individuals who are using canes, walkers, or baby strollers also have easier access. So, sometimes if a workplace workplace accommodation is put in place, it might be something that other workers think might help them as well, and maybe that's not a bad thing. I think typically a lot of people in the industry tend to think that workers will use something to their advantage or try to get out of working or take the easy way out or complain. But I think in a supportive environment, when people are accommodated, people generally do want to work. They do want to contribute. And if they don't, that in and of itself is indicative of a mental health problem. So, yeah.
All right. Someone asking, do you think self-medication is impacting mental health issues in the workplace, i.e. pot, alcohol, etc., specifically causing increased mental health issues?
That's interesting, and that was definitely a train of thought that came up during my research, and it's definitely something worth exploring because people had a hard time between distinguishing a worker who had a substance abuse problem and a worker with mental health issues. Even from a management perspective, is it a disciplinary process or is it a mental health supportive process? So there's definitely that intersection there. People are definitely self-medicating in the workplace. And it's problematic, as I said before, policies and procedures. Is that a disciplinary action, or is that a call for help, or a mental health problem? And I don't think the workplace right now is equipped to deal with it, recognize it, acknowledge it, and act fast on it. But I think it's going to become more and more prevalent.
All right. I don't think we have any other questions at this moment. So I guess I'll go ahead and wrap up the webinar. Thank you so much, Cindy, for your presentation. Really, really interesting and a really good perspective on the whole topic. We've done quite a few webinars on mental health in the workplace, and I think this really adds another layer to that discussion and to those topics. So thank you very much for the presentation.
Oh, thank you so much for having me. It was a pleasure.